Welcome back. I'm Angelo Sinopoli, one of the co-chairs of PTAC. We've invited 4 guest experts who have unique perspectives to share on best practices for incentivizing improved outcomes for patients with complex chronic diseases or serious illness and total cost of care models. You can find their full biographies and slides posted on the ASPE PTAC website, along with other materials for today's meetings. I will now turn it over to committee member Terry Mills to introduce our presenters and facilitate this listening session. Terry, please.
Thanks so much, Angelo. Excited about this session. Some exciting experts to present to us about best practices incentivizing improved outcomes for these patients with complex chronic conditions. I'm excited to hear about their experience and recommendations. We're going to start with Marie Bresnahan. I'll ask each person in turn just to introduce themselves briefly and then give us your presentation. So Marie, please take it away.
Thank you so much. Good afternoon. My name is Marie Bresnahan. I'm the Director of Training, Policy, and Administration in the Viral Hepatitis Program at the New York City Health Department. I'm joined here today by Dr. Bruce Schackman, a distinguished professor in the Department of Population Health Sciences at Weill Cornell Medical Center. And let me start by describing Project Inspire. Next slide, please. Project Inspire was funded by CMS as a 3-year Healthcare Innovation Award designed to implement a care coordination model for treatment of the Hep C virus, or HCV, for high-need patients in New York City. This model was designed to move care for hepatitis C out of specialty clinics, primarily infectious disease and gastroenterology, and into primary care. For this project, we worked with clinics located in East Harlem and the Bronx, which were affiliated with Mount Sinai Medical Center and Montefiore Medical Center. We developed a multi-provider bundled episode of care payment model, which was designed to move treatment for Hep C into primary care and provide care coordination and support to patients through treatment to cure. This was presented to the PTAC back in 2017. So I want to describe a little bit more about the target population. Next slide, please. When our project was developed, the majority of people with chronic hepatitis C had been infected in the 1960s and 70s. They were baby boomers born between 1945 and 1964. The demographics of people infected with hepatitis changed as many more young people began injecting drugs because of the opioid epidemic, and now we see high rates of hepatitis C infections among 2 groups, ages 25 to 45 and 55 to 70 years. An estimated 40% of people living with hepatitis C have comorbidities, including behavioral health issues, substance use, and chronic diseases such as HIV, diabetes, and kidney disease. As many of you probably know, people with a history of injection drug use are most commonly, that is the greatest risk factor for hepatitis C, injection drug use. So I'd like to describe a little bit more about the current state of hepatitis C on the next slide, where you will see that hepatitis C remains a leading blood-borne infection in the United States. And despite the availability of direct-acting antivirals, incidence for hepatitis C has tripled due to unsafe injection practices associated with the opioid crisis. Incidence and mortality associated with cirrhosis due to hepatitis C has risen steadily since 1990. And the treatments now for hepatitis C are significantly less expensive than when they were first available. And many of the health insurance barriers, such as prior authorization requirements, have been removed. So the major medical societies, such as AASLD, have developed a simplified treatment algorithm, and much of the treatment for hepatitis C is moving to a test and treat model. And treatment is being provided in many places, including jails, prisons, homeless shelters, substance use treatment programs, as well as in primary care. So despite these advances, the current care cascade using national laboratory data shows, on the next slide, please, that overall, only 34% of people diagnosed with hepatitis C have been cured. This study used more than 1.7 million people nationwide diagnosed with hepatitis C between 2013 and 2022, which represents the first 10 years when safe and highly effective cures for hepatitis C became available. Other data in this study found that only 1.4 adults under the age of 40 were cured. Cure rates were highest among adults 60 and older with Medicare and commercial insurance, and yet still less than half of those folks have been cured or were cured when this study was completed. So we're leaving many people with hepatitis C in this country behind, nearly a decade after curative treatments have become available. So I'd like to credit Dr. Rachel Florence, Senior Advisor to the White House on the National Plan for Hepatitis Elimination, for this and the next two slides. She recently presented these slides in New York, and they clearly spell out the need to ramp up treatment for hepatitis C to promote better health and economic outcomes. On this slide, you'll see the National Bureau of Economic Research did projections and found that increasing treatment for hepatitis would have clinical benefit, including reduction of hepatitis C-related hepatocellular carcinoma, you see in the top left chart there, liver-related deaths on the top right, diabetes on the bottom left, and chronic kidney disease in the bottom right, over 10 and 20-year projections. And increasing treatment for hepatitis C would have economic impact as well. On the next slide, you'll see projections found that increasing treatment of hepatitis C would result in $18.1 billion in cost savings over 10 years and $57.1 billion over 20 years. So let's get back to the work we did in New York City with our Healthcare Innovation Award. On the next slide, which you will see was designed to provide treatment for hepatitis C to Medicaid and Medicare patients that included comprehensive social determinants of health, assessments, integrated behavioral health services, and medical care. Our work on Project Inspire was designed to demonstrate better health outcomes and demonstrate cost savings, which you can see on this slide. So although we were able to demonstrate success with our model, the current healthcare environment is still not well equipped to treat all of those with hepatitis C who need it. On the next slide, you'll see some of what we think is missing. We need more primary care providers who are comfortable treating hepatitis C using the simplified algorithms. We need care coordination, which was found to reduce barriers to care and improve patient outcomes, particularly for hard to reach and hard to treat populations. We need care teams that include people with lived experience and those able to support patients through the process of screening, treatment, and cure, and payment models that support this care coordination and the peer specialists that would help us increase the number of hepatitis C patients treated and cured. And thanks to recommendations from the PTAC, we explored the use of complex care management codes previously and found that these codes were not widely used and that CCM payments were insufficient to fully reimburse the costs of this model. So what worked on Project Inspire, on the next slide, was telementoring, which allowed non-specialist providers to receive training in hepatitis C and created knowledge networks where clinical guidance and case studies could be discussed, and care coordination. So non-licensed care coordinators delivered health promotion and coaching and other services to support patients through care to the cure. Our model also included peer specialists with lived experience who conducted outreach and provided support. Next slide. On Project Inspire, we also looked at how to reimburse these services. And we found that a potential payment model calculated in 3 phases, which would support the kind of care you see in this table on the slide for patients from enrollment to treatment initiation, from treatment initiation to treatment completion, and a bonus payment for getting patients to come back for laboratory evidence of successful outcome, also called sustained viral response, to verify that they had been cured. In conclusion, on the next slide, we've outlined what we think are some implications for policy and practice. That a multidisciplinary team with care coordinators and peer specialists focused on curing Hep C proved effective, and a similar approach could be used to support other complex chronic conditions. That a payment model, including a bonus payment to support the telementoring that would not have been otherwise reimbursed. So telementoring requires some funding to support the time that a specialist spends with the primary care providers to teach them about how to treat Hep C patients. And that savings will accrue for caring for complex patients appropriately in non-specialist settings, avoiding the downstream medical costs from untreated hepatitis C. So on our last slide, I just want to thank my many colleagues at the New York City Health Department and our partners who worked with us on Project Inspire. The next slide, please, outlines our clinical partners at Mount Sinai Medical Center in Montefiore. We also had pair partners from Health First and Select Health, the Visiting Nurse Service of New York, as well as my colleague and his partners here at Weill Cornell Medical Center for the Center for Health Economics and Treatment Interventions for Substance Use Disorder, Hep C, and HIV. So Weill Cornell worked with us throughout Project Inspire to help us develop the payment model. And the last slide just has our names and contact information, and we are available for questions.
Thank you so much for that great explanation of your project. Appreciate your presentation, Marie and Bruce. Dr. Schackman, I apologize for leaving you off of the initial introduction. Let's proceed on with Jason Feuerman, President and CEO of LTC ACO.
Hi, good afternoon. Thank you for having me and the privilege to present to the PTAC committee. Just to give you some background really quickly, I come at this from dealing with the Medicare, very high-risk Medicare Advantage patients over the last 20 years, plus over the last 10 years, working not only with the bundle payment system that came out of CMMI, but operating the largest and most nationwide accountable care organization through the Medicare Shared Savings Program. And so a lot of what I'm here to share are thoughts, our opinions, or things that we've learned through both being a payer and working within the fee-for-service world. So next slide, please. So I think this first bullet is extremely important. Not having financial incentives will never change the outcomes, regardless of the population. Physicians work in a productivity model, and they must be incented to help drive down costs and rewarded for driving down those costs, or things just won't change. Financial incentives should not be identical for all populations. So whether you're dealing with a high-risk dual-eligible population, or you're dealing with a high-risk nursing home population, or we're talking about disease-specific complexities, having one financial incentive program for a group like that doesn't necessarily work. It really should be targeted so you can be assured you're getting to the right providers who are dealing with the intended population. Financial incentives obviously must be meaningful. The number one feedback we get from, or we've gotten from providers is, if it's not meaningful, I just don't have the time nor the staff to bear the cost of taking that additional time for complex populations. So it's extremely important that they're meaningful, whether that's coming out of the payer world or as CMMI and CMS are coming up with and refining different models. Financial incentives, I believe, must be an integral part of that, and make them meaningful enough that providers are willing to take that extra time to care for these patients the way they need to be cared for. And then finally, and really extremely important, if financial incentives must be provided in a timely manner, and that's timed to the projected outcomes. So as we think about some of the programs, for instance, that have come out of CMMI and CMS, specifically the Medicare Shared Savings Program and other population-based programs, those shared savings do not get paid to the participants until about 9 to 10 months after the end of a calendar year. So it's very difficult without some creativity within the program to really align the effort and projected outcomes with the payments. And so to get a provider's attention, they need to be more closely related. So next slide. So a properly designed program really needs to focus in on, and I just gave a few examples here, but, and they're really the high cost entry points into our healthcare system. And so what we look to measure is the use of emergency room versus an urgent care setting or the proper specialist or primary care provider. Obviously, for a high-risk population that's highly compromised, going through the emergency room will more than likely turn into a hospital admission. So that should be measured. Proper utilization of specialty services is also something that needs to be zeroed in on, especially as we think about the last presenter talking about hepatitis C. If they're not with the right provider, they're probably not going to get the care that's going to yield the best outcome. And then we need to be looking at over and, more importantly, I'll talk about this a little later, but underutilization of services. Other key components, because so many folks think that, they're dealing with a high-risk population. CMS does have a way, not a perfect way, but CMS does have a way to adjust for the acuity of a population. And that's generated by ensuring that there's accurate and complete ICD-10 coding for risk adjustment purposes. And this is called the HCC program. It's embedded in the Medicare Advantage program. It's embedded in the Medicare Shared Savings Program, as well as many states have adopted it for their Medicaid programs as well. And then an important guardrail that needs to be in there is that quality measures need to be meaningful to serve as an imperative, kind of a guardrail to ensure the efficacy of a model. Next slide, please. So I think very quickly, components of a program, well-designed program, really needs to be simple so that providers understand it and people can explain it to them and it can be implemented. Number two, transparency is extremely important. In too many programs, whether that's coming out of the fee-for-service world or coming out of the payer world, data transparency, either intended or unintended, it creates a rub between the payer and the provider. Also works to discount the results that you get from the program. Relevant metrics is an important piece of the program, obviously. And that's why when we think back to the first or second slide, I indicated that you can't have one reimbursement, one incentive program for a multitude of disease states and populations. They should be very specific and relevant. And then I spoke earlier about the quality measures, so that a provider isn't so focused on just the financial aspect, which, while important, if it's not guarded well with quality, it will lose its efficacy and will lose its ability to be adopted in a greater sense. Next slide. And so as we think about developing models, there's always going to be unintended consequences. Providers are thinking, well, if I'm being provided to give better care or incented to provide better care, and in a total cost-based environment, then really I want to do as much possibly as a provider to contain cost, and that can be a real detriment to a program, and one that is obviously very unintended. So we look at underutilization of specialty care. So if you've got dialysis patients and are not being under that situation, it's probably a bad one because they are being seen by nephrologists. But the diabetic who isn't being seen by an endocrinologist, being treated specifically by a primary care provider that may not specialize in diabetic patients could be very risky. The underutilization of home and community-based services is another area. A lot of these folks are susceptible to non-medical issues that create medical issues that send them back to the hospital. And so there are plenty of home and community-based services out there that should be leveraged. The deferment of services to reduce costs being measured under a value-based program can't be overlooked. It's not good enough to say we'll put off that EKG, for instance, for another few months for the sake of saving money, and meanwhile the person's in heart failure and costs the system 100 times more money than the cost of the EKG. And then too much focus on the patient complexity while overlooking aspects of care and social determinants of health. And that's really kind of ties into the second bullet. It's extremely important that all the right components of the healthcare delivery system, whether that's clinical or non-clinical, is properly leveraged. And then again, getting back to quality, if there's a perception out there that this is all financially driven without quality outcomes being measured and being rewarded as well, or penalized because of lack of quality care, providers can get disenfranchised with the program. So, and I believe there's another slide. So in terms of lessons worked, what doesn't work, and I hate to be negative in putting that first, but I think it's extremely important. What doesn't work is not accounting for and properly recognizing the acuity of the population being served. And what I mean by that is you have these very serious populations out there that drain the healthcare system from a cost perspective, and not really being able to properly recognize that acuity and accounting for it is something that could undermine the efficacy of the program. Not providing timely payment for performance, not necessarily on an annual basis, but maybe on a quarterly basis. We found that in Medicare Advantage world to be very beneficial. We've even gone as far as implementing that under the Medicare Shared Savings Program in certain situations, assuming that all providers will respond to financial incentives. That doesn't hold true. There are plenty of providers that either their business model doesn't allow for it, they don't have time for it, or they're just, for whatever reason, they're just not interested in responding to financial incentives. And then penalties. We saw this in the early introduction, particularly out west, with Medicare Advantage with a lot of downstream risk, where the providers themselves, if they didn't perform well, were giving money back to the Medicare Advantage program, and that's something that after a while just evaporates any value of a financially based incentive program. So what does work? As I indicated, payment as close to the time of performance as possible. Risk adjusting for the population served is very important, but it's one that should be looked at very, very closely to ensure that it's properly adjusting for the population and not just from a numerical perspective. Providing regular performance data to providers, I've always felt is one of the most critical things in making a program like this work. You're really, in my opinion, waking up an ecosystem by creating that transparency and giving providers information that they don't necessarily have on their patient population and the utilization of services outside of their scope. And so that's extremely important. And then proper education of providers to the incentive being offered. So just rolling a program out there is something that could be troublesome for a program. You can go back. Can you go back one slide? Yeah. Can be troublesome to certain providers. So being able to keep it simple so that the individual charged with speaking to the provider or providers can get their attention and can have a greater chance of getting the incentive program across and making it more effective, and thereby not only containing costs, but getting better quality outcomes. And then finally, the next slide, conclusions. Thank you. Yeah, it's working with all providers to create the value-based and quality-driven performance incentives, especially those for high-cost patients, obviously, that consume a disproportionate amount of cost and time. So in looking at programs, there is a theory that you don't want to necessarily just incent, say, a primary care provider, but work on incenting for population, but work on incenting different providers along that specific continuum, so that you're creating alignment within that delivery system. The next bullet is encourage CMS and state Medicaid programs not only support but participate in the initiative beyond the current programs run by CMS and CMMI, including examples such as Medicare Advantage and Medicare Shared Savings programs, making that almost an integral part of participating in these programs, because it's one thing to incent and generate savings and share savings with the ACO itself, for instance, or with the Medicare Advantage program itself. But if it doesn't make its way down to the provider level in a timely manner, that it probably won't work and have the most desired outcome as expected. And unless financial incentives become an inherent part of our provider reimbursement structure, which it really isn't today, which is unfortunate, changes to outcomes and performance will be greatly limited, constrained, and unachievable. So I think that goes without saying, just the importance of these incentives to get out of that production-based environment, one that's more grounded on better outcomes, both for the system and most importantly for the patient or beneficiary. And with that, I think that's the end of my presentation. I want to thank you all.
Wonderful. Thank you so much, Jason, for that insight. We will come back with questions after the end of all presentations. We'll turn now to Dr. Bruce Leff, Professor of Medicine and Director of the Center for Transformative Geriatric Research at Johns Hopkins. Bruce, take it away.
Coming off of mute. Thanks very much. It's a pleasure to be here, and I think my comments will resonate with both Jason and Marie's comments. I've been asked to talk today as a geriatrician and health services researcher, someone who's been interested in quality of care, delivery of care, especially in home and community-based settings, to talk about quality outcomes across settings for folks with serious or complex chronic conditions. Think about data sources and measures. And if we go to the next slide, just want to first present a few caveats. I think you're aware of most of these, but just want to try and tee them up perhaps in a unique way, thinking about this population, see if there are any learnings or insights from existing clinical or payment models that could be of use to us, and then talk about some associated issues that I think it's important for the PTAC to be aware of. So next. So some caveats on how to monitor quality, patient outcomes, and quality of life for these patients. And just by starting off by saying the nature of these patients makes this a particular challenge, and a few caveats. So starting with next slide, number 1. It's first of all, I think, really dangerous to assume that these patients are getting care. They are often an invisible population. So these are data from Kaiser Permanente. They're members, but not necessarily getting care through Kaiser. They looked at their 100,000 or so most complex patients out of a population of several million, did some latent class analysis. One of the classes they identified were the frail elderly in red. And if you go all the way to the right-hand column, you'll see that 27% of the most frail elderly, the most complex, had zero outpatient visits in the previous year, but still had among the highest mortality rate and the highest rate of hospitalizations in this entire analysis. And next, caveat number 2. There's a tremendous amount of heterogeneity in the population. So these are actually Medicaid data, somewhat dated, but the principles apply. The tails of morbidity are long and complex. Single disease constructs, there are some exceptions, but with rare exceptions, are often irrelevant for care or quality assessment in this population. And if you think about cost, we often talk about cost as if it's just one thing when you're targeting patients, but is it the cost for the illness? Is it a cost for the illness plus associated conditions? And there are many ways of slicing and dicing. Next. Number 3 would be that many critical factors highly associated with quality and outcomes are not captured in claims or even structured electronic health record data. Things like functional status, social constructs, going back to what Jason said. We did a study where we looked at claims data, structured EHR data, and in green, we actually did some natural language processing around text data in the records in over 18,000 patients. So if you compare the green, the text data, to the blue or red structured data, for some items, so for instance, lack of social support, you're more likely to find, you're 455 times more likely to find that information about a patient compared with structured data. And next. So the status of these patients is not static, and it's associated with very high mortality rates. So this is a study we did looking at incident homebound in that left-hand column. Folks who are not homebound in the previous year become homebound, and then we look to see what happens to them over the next 6 years. 66% of them are dead within 6 years, but you'll see that status in terms of homebound can vary quite a bit over time. You're homebound, maybe you're permanently homebound, but maybe you vary between various homebound states. So thinking about that is important. And 5, care provision is not centralized. So this makes attribution a significant problem. These data are almost 20 years old, a New England Journal article. And if you look at folks with more than 7 chronic conditions, the median number of physicians seen is 11. Median PCPs, primary care physicians, median is 3, and the median number of specialists is 8. A big challenge. Next. So a question for you all is the top 5% of spending the right target? What's really the North Star of this effort? Is it to keep spending down, maximize quality, finding patients with rising risk and keeping them from getting expensive? I think if you just focus on spending thresholds, that's an error. And I think it's useful to keep in mind you can only improve quality for patients who are getting poor quality care, which in probably most patients, quite honestly, but you can only save money on patients who cost money and have preventable cost. A lot of talk about 20% costing 80%, but not all of that is preventable. And next. So to that point, this is a terrific study from Jose Figueroa and his group up at Harvard. They did various slicing and dicing of the population. So if you look at that second set of columns from the left, frail elderly are about 8.6% of the Medicare population, but constitute about 51% of preventable cost. Important. And studies estimate that the preventable proportion of Medicare costs is on the order of 5 to 10%. It's not that 80%, but 5 to 10% of a big, big number is important and worth focusing on. And next. So some learnings, are there learnings from other models? Next. So these are some data from the Independence at Home demonstration from CMMI. I think this is probably the most underappreciated and probably the most successful CMMI demo. This demo, which focused on folks who are homebound, receiving home-based primary care, interdisciplinary care, had 10 times the savings of per year savings of ACOs and averaged about 9% savings per year. It was a shared savings mechanism and actually achieved success, not adhering to many of Jason's very excellent recommendations in terms of getting money to providers quickly. That was a big barrier and could have been more successful. And next. So the Independence at Home quality metrics that were used were things like follow-up contacts within 48 hours of hospital admission and ED visits, MedRec within 48 hours, all-cause hospital admissions, annual documentation of preferences, and I think Diane will be talking to that. I put the two in red at numbers 5 and 6, hospital admissions for ambulatory sensitive care conditions and ED visits for ambulatory sensitive care conditions. I don't think those are particularly useful. Next. I think it's useful to look at the ACO REACH quality measure set, which is actually pretty good. They have some claims-based measures, all condition readmission, risk standardized, all cause unplanned admissions with multiple chronic conditions. A nice one, days at home for patients with complex chronic illness in the high needs ACO only. And then timely follow-up after exacerbations of chronic conditions. These feel more aligned with the care patients with serious illness and complex chronic conditions need, and also importantly includes a component of patient experience. Next. So, thinking about additional dimensions or constructs of quality to think about, I think these are all things worth, putting on the whiteboard. They're often difficult to measure, but, access to specialty care, provision of urgent care. In a lot of qualitative work that we've done, provider competency is often a huge concern of patients, one that is really often not addressed. There's literature on goal attainment approaches to quality, which may not quite be ready for prime time, but I think are worth thinking about. Continuity of care and care fragmentation and care coordination measures also evolving. And then end-of-life care, hospice referral rates, death in preferred settings worth looking at, and long-term care placement. And next. So, I think it's useful to think about a core set, something along the lines of ACO REACH, but then I think it's very useful to think about structure and process requirements for the kinds of care these folks receive. So interdisciplinary care, team and structure, very important here. 24/7 clinical responsiveness, and not a phone tree that anyone, that someone with an IQ of 100, IQ of 150 to get past. They need to be able to talk to people at 3 o'clock in the morning with people who know them. Principle of comprehensive assessment, monitoring care across settings, having concurrent palliative and disease-directed care, appropriately targeting patients and services, very critical to integrate medical and social supports for this population. Caregiver supports, critical. Having explicit financial incentives, as Jason alluded to a few moments ago, very important to allow the entry of smaller practices. Very important here. They can do this and they can save money too. And ongoing, what I would call real quality improvement. And next, coming towards the end. So what about quality improvement? There's really 0 point in measuring and monitoring quality of care unless on the practice side, there's some incentive and some ability to actually do process improvement. I think I don't see that terribly often in my practice or in a lot of practices, and I coordinate a learning collaborative of over 90 home-based primary care practices from around the country. This is, not just checking the box quality. And next. A major culture issue in terms of this. I would submit that there is somewhat a facility-based care hegemony with little or no recognition for non-facility-based care. So in the context of quality, the recently implemented complex care codes did not include home-based visit codes in there. Those providers cannot access those codes. We did some work a few years ago looking at the MIPS measures. 50% of MIPS measures applicable to this population do not include home-based visit codes in their denominators. That's just absolutely absurd. Next. So some key takeaways. I think it's my last slide. It's a very complicated population. Really need to clarify the North Star of this type of work. There are some signals from existing programs, I would say, especially independence at home. I think creating high-level requirements for key structures and processes and having a few key outcome measures is the way to go. I would keep away from disease-specific outcomes, agree with Jason on explicit financial incentives and methodologically appropriate evaluation, and the need to recognize non-facility settings for this kind of work, because that's where a lot of the care happens. And I think I'm done.
Outstanding. Thank you so much, Bruce. We will turn next to Diane Meier, founder of the Center for Advanced Palliative Care. Please take it away. Diane, I believe you're on mute.
There we go. I'm unmuted now. Thanks very much, and I appreciate the opportunity to present. I was asked to speak about best practices for integrating and incentivizing palliative care and hospice in population-based total cost of care models. Next slide, please. So I just want to remind everybody what the definition, and this is a CMS definition of palliative care is. It is patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. It is delivered throughout the continuum of an illness, which may be decades in length, and involves addressing physical, intellectual, emotional, social, and spiritual needs. And in this sine wave graphic you see underneath, from the point of diagnosis through many, many years of treatment, patients need and deserve simultaneous access to both palliative care focused on their quality of life, their function, their social needs, as well as best available disease-directed treatments at the same time. And you note in the green arrow on the right, hospice really is not relevant until people are no longer benefiting from disease-directed therapies. And let me point out to you that disease-directed therapies are both life-prolonging and often they are palliative. So treatment of heart failure relieves symptoms. Treatment of COPD relieves symptoms. Dialysis relieves symptoms. Cancer care improves quality of life. There is no clean distinction between quality of life focused treatment and disease-directed therapies. And disease-directed therapies are often helpful and effective very, very long into a disease course. Next slide, please. So who are these patients? Similar to what Bruce said, they're hugely heterogeneous. They have more than 6 to 8 simultaneous chronic conditions. They see a median of 8 to 11 different physicians per patient per year. They have a high level of functional and cognitive impairment. They have a high burden of symptom distress, not only pain, but many other symptoms as well. They undergo multiple transitions in settings. Their caregivers are exhausted and overwhelmed. They end up using 911 to manage symptoms and caregiver exhaustion after 5 p.m. and on weekends, because really there's no one else to call other than 911. If you call your doctor, you get a tape that says, if this is an emergency, hang up now and call 911. And they're expensive because they are really sick. They are really complex. They need care from a lot of specialists. And as Bruce said, much of this spending is in fact not preventable. Next slide, please. Just want to make the point to you that unpredictable, unplanned ED visits are largely due to a symptom. Sometimes they're due to falls or trauma, but a large number of them are due to pain, shortness of breath, dizziness, fatigue, inability to manage one's own activities of daily living. And just between 2012 and 2019, there was a 100% increase in the number of patients with any diagnosis visiting an emergency department because of pain. Next slide, please. This is a patient that I met 12 years ago and I'm still caring for. Her name is Debbie. Next slide, please. You can see she is a hairdresser. We met her 12 years ago when she had been in the ED 4 times for pain crises related to the consequences of her bone marrow transplant for multiple myeloma. When we met her, she was in disabling pain, had depression, functional impairment, inability to work. She was the sole support of her daughter and granddaughter. Lots of suffering and family distress. She had to call 911 many times for pain crises, was accused of being a drug seeker on more than one occasion by colleagues in the emergency department. And finally, on the 4th ED visit, someone in the ED contacted palliative care. We've been taking care of her side by side with her hematologist for the last 12 years. Her pain is hard to control, but it is controlled. She has very complex pain syndromes. She's been able to return to work. She reaches us 24/7. There's a 24/7 palliative care phone number. Someone who can see her chart answers the phone. She sees hematology every 6 weeks, and we see her on the same day in a different building. She gets a lot of support from our interdisciplinary team, especially our chaplain, and she has not once been using 911 or in the ED since we met her, and she is not dying. Next slide, please. So lots of data. I won't expose you to all of it, but the reason palliative care saves money is not because we are rationing. It is not because we are withholding needed care. It is because we are meeting the needs of a very complex, seriously ill, multi-morbid population in the community. So if we're managing symptoms, if we're paying attention to family needs, if we're communicating with all of the 8, 9, 10 other doctors, we're often the quarterback for these patients. Costs go down, not because we're trying to reduce costs, but because we're trying to improve quality. So you can't get the cost reduction if you're not delivering the quality. And next slide, please. And the structural requirements, similar to what Bruce mentioned, and payers can create structural requirements and should. You have to have an interdisciplinary team that at a minimum includes somebody trained and certified who is a prescriber in palliative care and a clinician who can provide psychosocial and spiritual care. A social worker, a chaplain are essential to the care of these patients and their families. The clinical team has to be reachable by phone 24/7. And that means reachable by phone within 15 to 20 minutes at the longest. If a patient is at home and can't breathe and no one calls back, the family member is going to call 911. So timely responsiveness is essential. Next slide, please. So this is a publication from the organization that I work for, the Center to Advance Palliative Care, that identifies best practices for integrating palliative care into population models. And it's the usual series of steps: systematic, proactive identification of the highest risk people, care management assessment of those that are identified for symptoms, for functional needs, and for caregiver needs, communication with the other 8, 9, or 10 treating physicians about these issues, or referral to specialty palliative care. Specialty palliative care dosed, so we still take care of Debbie 12 years later, even though she hasn't needed to come back to the hospital. And I think that's why she hasn't needed to come back to the hospital. And again, 24/7 meaningful response. Next slide, please. So these are the risk factors. In my hospital, the Mount Sinai Health System, a multi-billion-dollar system, we do not routinely screen for these very high-risk patients and identify them either on the outpatient side or on admission to the ED. If they have to be lucky, I would say, to get seen and then referred to a palliative care team who will follow them in the community. It's not systematized, but it can be systematized. And I will tell you that United Healthcare, through its subsidiary Optum and its subsidiary Landmark, is doing a really good job at identifying Mount Sinai's highest risk, highest cost patients. And they call us and say they're taking care of our patient who they identified through their basically their machine learning, but the health systems are not incentivized to do this. Next slide, please. As everyone has said, explicit incentives are clearly necessary. We've been experimenting with value-based payment for over 10 years. They have not changed the behavior of clinicians. So we need two things. We need meaningful financial incentives that actually change behavior and explicit requirements. We can't say, well, because of value-based payment, everyone's going to start paying attention to palliative care. That did not happen. Next slide. Here's just a few examples of financial incentives working. The example for hospitals, Elevance, which used to be Anthem, palliative care had a quality health improvement measure. Network hospitals received a explicit financial bonus for having a palliative care policy, having standardized patient identification algorithms, having an interdisciplinary team. They required at least 2 of the relevant disciplines in palliative care and mandatory annual all-staff training. And those have both been sustained and been successful. Highmark in Pennsylvania, Blue Cross Blue Shield plan, provides network hospitals a financial bonus if more than half of enrollees that Highmark identifies using its enrollees receive palliative care services during a 30-day episode. That's also been successful and sustained. Next slide, please. Here's examples of financial incentives working in the community. Cambia in 4 states in the Pacific Northwest, Blue Cross Blue Shield plan provides a financial bonus for network primary care providers to have goals of care conversations with enrollees and for referral to palliative care services. So they're explicitly paid extra for referring to palliative care in people who screen in. Highmark, Blue Cross Blue Shield provides a financial incentive for primary care providers if they refer to what's called enhanced community care management, which is really sort of like a cross between independence at home and home-based palliative care. And they get explicitly paid more if they identify high-risk enrollees and refer them. And this has shown a consistent reduction in total cost of care. Health First, which is our major Medicaid and duals managed care plan here in New York, network ACOs received additional payment from Health First for a 90-day episode of home-based palliative care services for patients who screened in using the algorithm. Next slide, please. So these are the options. I think we're essentially a choir here or a broken record. We need to require hospitals and systems participating in population-based models to attest to having a palliative care policy, a patient ID process, an interdisciplinary team, and all staff training. Total cost of care model participants should be required to report regularly on the number and percent of high-risk patients receiving specialty palliative care. We should financially incentivize the delivery of palliative care through a care management fee or a quality incentive, without which hospitals and health systems will not provide the necessary resources to ensure palliative care capacity. We need a CPT-G code because right now we cannot count who is getting palliative care and who is not through coding. And we should use patient-reported outcomes as quality measures. This is a very sick and complex population. Knowing that patients felt heard and understood by their team and received the help they desired for their pain are really relevant to this patient population. And these are both NQF endorsed measures and have not yet been integrated into CMS programs. Next slide, please. For hospice integration, I think we already know from the early work with the Medicare hospice integration model, referral should not require terminating other services. So that's called concurrent or transitional hospice. And this is a major equity issue, particularly in vulnerable communities. In treating clinicians should be incentivized to continue to care for their patient. One of the major barriers to referral to PACE, for example, was the early requirement that patients had to give up their prior relationships with clinicians. People often they'd been seeing for years. And because of that requirement, many people refused to go into PACE. Those PACE programs that got a waiver and enabled patients to continue seeing their regular docs and incentivized that were much more successful. The same should be done in hospice. Most of my colleagues, once the patient is referred to hospice, they never speak to them again. And that is a huge sense of abandonment and blow, not only to the patient and family, but also to those clinicians. And then last, and again, 24/7 meaningful clinical response that is incentivized. Next slide, please. And these are 3 models of concurrent hospice care models. First is the Medicare Care Choices model, which showed 14% lower spending, longer hospice length of stay, more days at home, and much better inclusion of underrepresented groups. The VA Comprehensive End-of-Life Care Initiative, this was paid for through the VA budget. These patients were much more likely to die on hospice and less likely to receive hospital and intensive care in the last several months of life. And at University of Pittsburgh Medical Center, in a concurrent hospice and dialysis program, this was actually an individually negotiated payment rate between the local hospice and the dialysis center, and in which enabled the hospice to pay for the dialysis. Much longer hospice length of stay, much higher use of hospice, and most patients, when experiencing life at home with hospice, made the decision to discontinue dialysis, not because they were forced to discontinue it, but because they were able to make that choice later. Next slide, please. So this is my last slide, reiterating what lots of people have said before. One is that you need to explicitly require that these models are present, and that there's access to them, and that they meet quality standards. And financial incentives need to be real, meaningful, and timely. Thank you.
Thank you so much, Diane. Greatly appreciate your all's experience and perspectives shared with us. I think we've now got right at 30 minutes for question and answer for the committee members present to pose additional questions. I will look for any questions that come up. Okay, let's start with Walter.
Wanted to go ahead and thank our panelists for just a really rich discussion. And in many ways, I feel like this panel is one of the most important ones throughout our 2-day meeting, because PTAC is all about payment models and how payment models can better the delivery of care and improve outcomes. And we're focused on this population of the top 5%, to Bruce's point, for the reason that they account for such a big share of Medicare spending. Over 40% of Medicare spending is from this population. And I was actually a bit surprised to hear that only, according to the study that Bruce cited from Harvard, 10 to 15% of that spending is preventable. So 2 questions there. One, I'm curious if, Bruce, that's been your experience as well, and maybe Diane and others can speak to that. But I'm also very curious to hear from Jason as well. What kind of savings are your practices in long-term care ACO achieving? Kind of, you don't have to give us exact numbers, but just a general range. Is 10 to 15% preventable with kind of better clinical models, or is it greater? Is it less?
That's for me, right, Dr. Lin?
Yeah, it's for actually the whole panel, but
Okay.
definitely you as well.
Well, I'll go then. So we do, as you know, it's the adoption of the program, the adoption of the data, and once the clinician really grabs on and starts to not only question the data but engage with the data, it does result in a re-engagement type with the patient that does create a meaningful outcomes. In general, in that 10% range, plus or minus, but it is within that range and it is meaningful for very high cost patients.
Yeah, I would just add, Dr. Lin, the notion of 5 to 10% preventable, that's for the overall, right? So, a small proportion account for a lot of the cost, and a very high proportion of Medicare beneficiaries account for a very small proportion of the cost. I think last time I looked at that, 50% of Medicare beneficiaries actually account for 5% or somewhere around that percent of the cost. So, if you can implement, so it's kind of the Willie Sutton thing, right? Why do you rob banks? It's because that's where the money is. If you can only save money, as I said, on people who cost money. So and who have preventable costs. So frail elderly is not the only place to find preventable costs, but it accounts for a big chunk of that. And those are the kinds of patients that, Diane and I care for every single day. I would say that even in that context, there are clearly examples where people are doing good clinical practice to keep those costs down, but I don't know that that's ubiquitous. And I would say, to the extent, building on Jason's comment around having data to actually then do something with it, that ethic, that deep cultural DNA of taking data, doing something with it to improve care processes and reduce costs, I don't think that's deeply embedded throughout much of healthcare either. I think it's still much an eat what you kill kind of atmosphere. And because financial incentives are often not tightly linked to to getting a performance bonus, I think providers generally say, why bother? If I'm going to get an extra, 0.5% on income or whatever measure it is, it's easier not to then change process. Why bother? And I think that's a big part of it. Sorry to be cynical, but I think that's the water we're swimming in to some extent.
It's also what our employers want us to do.
Exactly.
They want us to do throughput and billing. And our health systems are not incentivized to manage total cost of care. To the contrary, we're constantly being beaten about the head to see more patients faster. You can't do that with these patients. I mean, I spent an entire day yesterday getting a patient of mine who broke her ankle and refused to go to the ED because the ED is a nightmare. It was a full day of my effort to get her seen by an orthopedist and into the OR today. That's a very expensive cost. Most patients don't have doctors willing to do that or able to do that or stubborn enough to do that. It was like a fight with the system all day long. Those are the things that we're asking clinicians to do with zero reward. And of course, most don't do it because they have to get home to their families. They have 60 people in the waiting room. The financial incentives need to be completely flipped to change that. We should be incentivizing care of these very complex multimorbid patients by paying those doctors way more than we pay orthopedic surgeons.
I mean, it's another thing we haven't really talked about today. Sorry to talk over you, Diane, but we haven't talked about issues related to workforce in this space, right? So geriatrician, palliative medicine doctors, ain't too many of us, right? Geriatrics is the one field you go into only to take a pay cut after your fellowship. So, it's still astonishing to me, for instance, that special needs plans do not have a requirement for having geriatricians leading those programs. That to me is insane and absurd. It'd be like having an oncology service not headed by an oncologist. Like, how would you do that? So, we haven't really talked about the workforce issue, but these kinds of payment incentives, were they implemented, were they taken up, could also have an effect, the kind of effect on workforce that I think we need to have moving forward.
Yeah.
Anyone else want to add to that? Okay. I'm sorry, go ahead.
Lee, I was trying to raise my hand. I guess it didn't come up.
Go ahead, Jay.
No, I really appreciate the candor that is being expressed today. I almost feel like the health system itself needs palliative care. That's kind of where we are. And if you think about, Bruce, to your point about the workforce, I mean, a lot of hospitals got rid of their geriatric fellowships because it cost them money. So
Right.
That's part of the issue. And if you look at the nature of palliative care and, how do we get there is because your everyday general internist didn't want to spend the time taking care of these patients. That's the reality. And it takes a special type of physician to go into geriatrics and palliative care who's willing to spend the time. So, and that's a systemic issue with our profession. And, somehow we've got to get to that. But, how much is enough to change behavior? And I'll put that out to all of you, because part of the problem is if the system gets the reward, a lot of the times it doesn't make it down to the practicing physician. Like Diane, like you said, they just want more throughput. So, how do we work it in so that the provider gets the reward for the incentive?
Yeah, I would say it's not only an amount, I think also it's the milieu, the work milieu. I think that, if total cost of care models created a world where volume was less valued, and where quality improvement was part of the core DNA of practice, you would keep physicians in the workforce longer. They would be able to spend more time. It's not just a dollar. I don't think it's simply a dollar amount, although that's important, no doubt. But I think if you ask many physicians who come to work each day and actually want to do good each day, they would, if you said, here's an algorithm, how much, if we improved your working conditions this much and raised your pay that much, would that be enough? And I think you'd see both sides of that equation being valued.
Yeah.
No one comes to work wanting to be a crappy doctor. No one comes to work not wanting to try and do what Diane did yesterday with her lady with the ankle fracture. I think we all would like to be able to do that. And it's actually kind of a miracle that Diane, even having spent all that time, was successful in getting that person to the OR. I've spent days doing that kind of stuff, and you know what? You fail because the system is just too unyielding. So, my bet is that Jason has some analyses that could tell us whether that number is 5%, 10%, 15%, but it does need to be meaningful. I think there are some clues from the Independence at Home demonstration, as flawed as it was in terms of the money flow. I think there are some clues probably from a high needs reach that will help people think about that as well. And there are probably some clues from organizations like Kaiser and Landmark and Prospero, where they're doing this in more of a capitated environment, if they will share their data with you.
I asked yesterday, they didn't.
And that's not surprising either. But I think there are ways to get signals on that, but it's not simply dollars. I think it's a bit more, it's potentially, and I think that's actually a good thing because it's not just the money, it's the system as well, it's delivery.
Wonderful. Thank you for that. Jay and team. We pass it to Jennifer.
I completely agree with Walter. This has been a very important discussion. And I have to, before I make my comments, acknowledge pediatricians and psychiatrists would say they're actually in that bucket also. I think, gosh, there's so much to say, but I'm going to start with a comment around the business case is always harder. It's considered soft business case to our CFOs around cost mitigation versus revenue generation. And I think that plays out here a lot. And I think the specific examples in the last presentation are very helpful about what currently exists around financial incentives for hospitals and communities in the private payer space. But I'm gonna actually come back to where we started, and that's in the workforce question. There's clear evidence around what exceptional care looks like, and your examples around financial incentives to try to nudge us to deliver that care is helpful. But the long game of financial incentives is workforce expertise. We're talking about how do we create short-term incentives that meaningfully change care delivery where we've got a workforce gap. So can you talk through that? What does that look like in the next 12 to 36 months of meaningful incentives that can also change the system to deliver excellent care? Knowing that there's this workforce gap. We can't have in my own practice, we don't have enough palliative care doctors to do this tomorrow. So is there a primary care-based model where this is successful? Can you talk to us about how do we acknowledge that workforce gap and align that with financial incentives?
Jennifer, it's funny, when you started the sentence 12 to 36, the next word I expected to come out of your mouth was years and not months. So
in full disclosure, I'm an emergency physician.
There you go. There you go. So I would agree that I think there are a few ways to look at workforce. Number one is to think about workforce in terms of worker bees, and we need worker bees. And I'm a frontline worker bee in geriatric primary care and home-based primary care. I think we also need to think about workforce in terms of leaders and leadership who can create systems and embed educational programs to bring along primary care physicians of all types, whether it's pediatricians or internal medicine docs or internal medicine mid-level practitioners or geriatric mid-levels. I think there are all sorts of ways to start to, inject knowledge, attitudes, and skills that need to be brought to the bedside over the shorter term. I do think also that, were payment incentives under total cost of care implemented such that it actually motivated systems to move forward, those systems might start to value the kinds of leadership that pediatric leaders and geriatrician leaders and palliative medicine leaders could provide, because we understand, not exclusively, but we understand settings of care. We understand how to think about functional status. We understand how to think about social determinants of health. I think in a slightly more enhanced way than some other specialties. And I think you then can create a leadership core that could help move systems forward. And I think to your point about systems valuing revenue, just one example, we took our home-based primary care program that was sitting in our academic division, losing $250,000 a year, and we proposed to bring it into the system, over to the health system where, in theory, economic incentives would align. That movement took, I would say, about 80 meetings. And it wasn't until meeting number 30 that the financial folks who had an Excel sheet that evaluated any new thing, that Excel sheet did not have a row for projected savings on it. So that's like a little widget in the system that doesn't even think about saving. So we finally got them to add that row. Then they saw the potential value in the model, and then they finally took it on, somewhat begrudgingly, I would say. But, you know, those are the kinds of like hardwired things within systems that actually prevent innovation, prevent this kind of development. And these are, you know, it's not trivial. It's really not trivial.
No.
I would just want to,
We eliminated our home-based primary care practice.
And that was the premier academic home-based primary care practice in the United States of America.
Right, because they couldn't use cost avoidance as an argument, and they were saving a lot of money. But they wanted that fee for service. They wanted those heads in beds.
so in terms of gaps, in a very sort of tangible way in our project, we relied on telementoring to enhance the abilities of primary care physicians to basically do something new and different. And we were fortunate that there was a technology out there that was not being adopted, and this was a way to make that happen. And there was no, as we were putting the payment system together, there was no payment mechanism to cover basically the time of the provider in the telementoring session rather than seeing a patient. So we calculated what that was, what that lost revenue was basically, and then suggested that there could be a quality bonus, which was allowed by the mechanism, or could be allowed by the mechanism, and that would be specifically targeted to fill that hole, so that from the organization's point of view, the revenue was not truly lost. And the providers were motivated to participate because they were their skills were enhanced, and they were able to see patients they hadn't been able to see before, and patients who were not going to leave primary care to go see a specialist. So it's a small example, right? It's very targeted, which is probably why it was successful, because it was very focused on a specific outcome in a specific complication that these complex patients had. But also, you know, we tried to figure out a way to get it paid for so that it didn't look like a loss.
Yep.
Wonderful. Thank you for that rich answer. I'm going to put myself into the queue and just, Bruce, you got me thinking this way, but I think it's an appropriate question that everyone will have perspectives on, which is pulling in strains of both lessons learned about what's worked in the literature and in your professional lives, and then aspects of data sources and measures. I'll ask you for a minute to cone down on identifying, so which of all these complex patients have preventable costs? You know, in full disclosure, until very recently, I was also boarded in hospice and palliative care, and for my 20-year private practice career in rural Kansas, I did hospice and palliative home visits routinely as part of my practice. And I could identify them when they walked past me somewhere in Walmart, and I said, that's a palliative care patient, right? Unfortunately, similar to the definition of art, you can't build programs and metrics and incentives around, I know it when I see it. So if you will, share your learnings about how you identify these patients. Is it a set of characteristics, diagnoses, events in a claim feed, or some, you know, risk predictive methodology that has seemed effective?
Yeah, I think it's a combination of things. You know, part of the issue is dealing with data that you can actually get your hands on, right? So claims tend to be the most easy to get at, and even those are not terribly easy to always get. And recall my slide where, you know, a lot of folks are not getting, you know, if you lack access to care, your experience may not be showing up in claims, or maybe not be showing up fully in claims. You know, in the example of independence at home, it was the presence of 2 or more of a specific set of, I think it was 11 or 12 chronic conditions that are particularly costly, and experiencing health service utilization in the form of a hospitalization, and having experienced an episode of skilled home health care or time in a skilled nursing facility. And the key issue there was, you know, it's not just number of chronic illnesses, but functional status, cognitive status are critical to this kind of conversation. If I have 5 chronic conditions, I might cost X. If I have 5 chronic conditions and functional impairment, I'm going to cost 2 to 3 times X. And the challenge is we do not capture functional status well unless you are getting into a skilled home healthcare episode where a skilled home healthcare agency has to fill out the OASIS assessment, which takes a few hours for a skilled home health agency to fill out, or if they get to a skilled nursing facility, and then the minimum data set questions need to be filled out so you actually get a signal on function. So I think critical to this effort, and I think it was in a slide that ultimately had to be pulled out, you know, some mandate for a standard way to assess functional assessment and get it done on people is critical to understanding and identifying this population. Independence at Home did not do badly. I think they did pretty well with that. There are also now claims-based ways to assess frailty, not perfect, but reasonable. And that is also something that can be used. I can tell you we're just finishing now a project with a large integrated payer provider with whom we were able to add questions on whether the person was homebound into their annual in-home wellness assessment. The prevalence of people who are homebound is about 20% in the Medicare population. If you look at people who never get out of their house and people who need help or assistance or have difficulty getting out of the house, being homebound is an extremely powerful indicator of utilization, mortality, and just lousy care experience. So there are these other things, and you know the system has to decide how they're going to collect it. I don't think perfect needs to be the enemy of a reasonable signal, but how to incorporate that into payment and performance payment, it's complicated, but it has been sort of done before.
But I think the key point to remember is that this information is not in claims.
Exactly.
And we use claims, we use utilization and ICD-10 codes to identify the high-risk population. So we're looking for our glasses under the street light because the light is better when we drop them at the back of the parking lot. So, you know, we do what's easy, not what's accurate. And so we're missing the boat. And if we started to mandate recording of cognitive status and functional status and caregiver stress and homeboundedness, lives alone, even just knowing someone lives alone is a key variable. It's not anywhere in claims, and it's not in the electronic health record either.
Yeah.
So all the key factors, many of which are social and behavioral, are invisible to the health system and to CMS.
Anyone else?
I'm just gonna add an accent to that point, Lee.
Sure. We've got just a few
think
minutes.
that is so important. I remember talking with Jose Figueroa when he ran that data in 2017, and the integration of health-related social needs and even the behavioral health diagnosis wasn't in that report. And in my work, I obviously have a biased opinion. I spent a lot of time in that space, but I think your study with the NLP pulling out the social support aspects and just the importance of that, it's another actionable area that we don't have line of sight into, and maybe one of the most promising areas to look at next.
Yep.
Thank
Your
you.
data on the costliest 5% highlighted, you know, area deprivation index as a major predictor. And, you know, we're just not picking that up in our algorithms.
Okay, we're down to just about 2 or 3 minutes, but I think it's just time for 45 seconds or so per person. What's the one final summary thought you would leave us with as we close down our listening panel for today?
I'll jump in, Jason Feuerman again. I think that these financial incentives need to be structured appropriately, but also need to be more mandated. by CMS, so it does get into the hands of providers. Because to several other people's points today, a lot of times it doesn't. And they're the ones on our front lines. And we're never going to change the paradigm when we think about this from a health system perspective. The CFO is never going to find the pay for. And in order to really bend this cost curve and bend the quality curve, the providers need to be incented. And so I would urge some level of mandate. I don't know what that exactly looks like, but start having that discussion. And whether that's sitting in the Medicare Advantage or whether it's sitting in fee for service or both, it can bend the cost curve at this point.
Thank you, Diane.
I agree. And that was really my major point is these services have to be required and they have to meet quality standards. And if you want to get paid by Medicare, you must deliver these services. You must demonstrate what fraction of the high need population is receiving them, and they have to be financially incentivized in order for the institution to allocate the resources. So requirements.
Yeah, I think the only thing I would try and add to that is the notion of trying to figure out how to link what Jason and Diane just spoke to real, true quality improvement, process improvement efforts, because the systems, when they hear requirements, will just check a box and try and collect the money. So I don't know how to thread that needle, but really linking to true quality improvement. And as Jason was talking about, and Diane, about requirements, the thought that just flashed was, look to the VA. The VA has done a lot with requirements around certain kinds of care delivery. So their home-based primary care services, which they have at each of their medical centers, they have a mandated membership on their interdisciplinary team. Their teams are the most robust of any teams you will see in the country, including mental health, including chaplain services, including a whole bunch of things that most systems outside the VA cannot put on a team, but they mandate it and they pay for it. So, there are models outside of VA practically invented geriatric health service delivery. There are some examples there.
Wonderful.
Our closing thought is maybe a little bit more hopeful that there are examples where targeted focused payments can make a difference. And don't let the perfect be the enemy of the good, and try to find some of these successes and design payments for those specific cases, and then maybe that will help build the momentum towards a bigger system change.
Yeah.
Thank you so much for your rich perspectives and hard-learned real-world experience and advice. Appreciate it. We're going to be turning now to a public comment period that you all are each certainly welcome to stay around and listen to. And at this time, I'll pitch it back to Dr. Weiler.
Sorry, I need to jump off. Take care.
So I'd like to thank all four of you for joining us this afternoon. And for those of you who are able to stay, we welcome you to listen to as much of the meeting that we have remaining. At this time, as Dr. Mills said, we'll have our public comment period. And if we don't have any public comments, we'll then move into committee discussion. Now I'd like to see if we'd had anyone sign up for public comments. It looks like we do not. So at this point, I'd like to move into the comments from our committee members. We will be discussing everything that we've learned today. As you know, PTAC will submit a report to the Secretary of HHS with our comments and recommendations based on this public meeting. Members, you have a document on potential topics for deliberation tucked into your binder to help guide the conversation. If you have a comment or question, please flip your name tent up or raise your hand on Zoom. Who would like to start?
Well, such rich discussion. I took pages and pages of notes that I have not had time to fully distill into a cogent synthesis, but this will be a little bit stream of consciousness. So I really appreciated Jason's hard-won experience about, what the nature of incentives must be to move the needle in the real world. And that, ties in a little bit with what we heard about, encouraging us to have a CFO or a finance-driven panel to ensure that it connects all the dots in a complex system. But the list of characteristics for incentives, they should be meaningful, timely, tied to appropriate performance metrics, quality. Interestingly, quality that is not really an inducement. Quality ought to be a guardrail or it's an impairment. It's table stakes, but that high quality expectation must be set out, plainly and transparently. He spoke to knowing that there's going to be consequences anytime you incent something strongly. There are unintended consequences, and think that through carefully and mitigate in advance. Spoke to careful applications in addition to a incentive and what incentives should be applied. There should be careful application of penalties, essentially the flip side of an incentive, which is interesting. And then spoke to risk adjustment and incenting providers along a continuum to get more engagement and more participation. So I thought that was a really nice list of things we've heard, frankly, over the last several years as we've been exploring these topics. Particularly struck with Jason's comments about waking up an ecosystem, and that speaks to my experience dealing with individual physicians and data that essentially goes through the entire stages of grief, and it's not until you get to acceptance that the ecosystem wakes up and they start engaging with data and start managing a process. And so that was powerful. We've heard refrains throughout this weekend that this complex, chronic disease population essentially definitely bats above their weight. A small percentage yields a great amount of cost. And refrains that many programs or incentives are built around a single disease construct that don't really work for this population, just because they're outside the bounds of any single disease construct, and that was really powerful. Heard pretty powerfully this afternoon that for this group of providers and palliative care especially, they're begging for a mandate. I mean, they're asking that requirements be tied to programs to get paid, and that was really powerful. And I wondered, is with all the data that we've seen and my personal reading, it seems like the data may be there, and maybe this is we can ask for a ASPE research project, but there may be data support saying palliative care is actually the second domain in addition to primary care, where simply increasing the supply leads to improved quality and decreased costs. And I think I sniffed that out a little bit, in which case a fundamental problem is that we're not identifying the patients. Again, everybody agrees you know it when you see it, but you can't build a program around that. And then they spoke to the challenges of there's no code. There's not enough. You can't use a specialty designator because there's not enough palliative care doctors or geriatricians. You miss a lot. There may be a cluster of, from the prior pilot, a cluster of some diagnoses plus an incident like hospitalization plus a certain cost threshold. I mean, maybe that can work, but that gets really complicated and leads to all kinds of reconciliation issues after the fact. So it made me wonder if there's a path CMOI could explore about essentially, I never wanted to speak about in favor of the proliferation of G codes, but maybe there is really an opportunity for a single G code incentive to start upstream with just identify these patients, and there's an incentive for identifying them. Because once you've identified them, then you can unlock more powerful things about dramatically lowering costs and improving outcomes. So that was the thought.
Excellent. Thank you. Lauran.
I know you'll be completely surprised, but I'm going to lead with equity. So we heard a really strong theme about the importance of really paying attention to equity in this equation, related to access, related to inclusion of people with lived experience and governance, patient-reported outcome measures as part of the equation for measuring quality and the opportunity, feeling heard and understood being a really key measure. And then really thinking about the importance of building a system where people have choice in this transition. So building a system that has 24/7 access for urgent needs, the ability to call and get symptom management support, caregiver support, and that 24/7 support is provided by someone who knows your story and has access to your complete record. Along with that urgent response, in order to get stabilization and outcomes in this population, it's also important to have explicit and concurrent care and proactive anticipatory care, which is new competencies for many people to teach, not the way our system works now, which is we wait till there's a crisis and then we respond, but really to understand how to proactively address symptom management, disease management, and include health-related social needs and assessing for caregiver and social support needs as part of that equation. The importance and opportunity to include peers and non-licensed providers with lived experience as part of this response offers promise and was brought up as part of this. And then really the importance of weaving concurrent care along with hospice and palliative care, so people really have choice and can transition along the road with stabilization. So I'll leave it there to leave my colleagues a little room to comment as well. Thank you.
Wonderful. Thank you, Lauran. Other member comments? Walter.
It's been just such a great couple days, and I first want to preface my comments by again thanking the ASPE staff, my fellow PCD team members, PTAC members, and NORC for just organizing a really rich 2 days of discussing extremely important topic. You know, we are talking about the disproportionate impact high cost patients have on Medicare spending. You know, the top 5% per capita spends $130,000 a year. That's just mind-boggling to me still. And the good news is that I think there's a lot that can be done to address this. There's a lot of opportunity to improve the care of this very small minority of patients. But it's going to take some focus and creativity in care model design. I had mentioned in my PCDD presentation that there are a few overriding key objectives in caring for this population of patients. And I was happy to hear various experts validate those over the course of these past 2 days. Those objectives include providing goals concordant care. We heard a lot about the importance of goals of care discussions, advanced care planning discussions. You know, it's hard to provide goals concordant care if the provider doesn't know what the goals of care are of the patient, as they state. The whole area of measuring patient-reported outcome measures around symptom control, pain control, around understanding the goals of care, I think was really insightful. Another important objective that we have for this population of patients is delaying the progression of chronic disease. And we heard quite a bit about the importance of intensive primary care for this population of patients, not with just any primary care provider who may not be trained or have the inclination to care for complex chronic patients with serious illness, but those with expertise in this area. So activated PCPs, I think, was a term that was used to really try to somehow enable their care of this population through better payment models. A third goal I had mentioned was to catch acute exacerbations early to enable outpatient treatment. And we heard both yesterday and today about the importance of availability, 24/7 availability to this patient. I think Diane had said you have to have a good response in 15 minutes, a meaningful response in 15 minutes. Dr. Smith said yesterday, same thing. We have to have on-call meaningful response to encourage these patients to reach out again and again. And then finally, I had said an important goal was to reduce treatment burden and focus on symptom relief. And we heard a ton about palliative care and hospice care and what that can do to not only improve quality of care, provide more goals in concordant care, but also improve, also lower costs. So I think it's all kind of coming together. I was actually, I'm leaving these 2 days a bit more depressed in many ways because I feel like it just highlighted how broken the fee-for-service system is in addressing the needs of the seriously ill and complex chronic condition patients that drive so much of Medicare spending. Just speaking from my own experience, we're the largest independent group of providers in the greater St. Louis area focused on the care of seniors living in nursing homes and assisted living facilities, seriously ill, chronic complex. We would love to hire a palliative care specialist into our practice, but I can't make the numbers work. The numbers just don't pencil out, right? It would for Medicare. I'm confident that the savings that the specialist would help generate would more than cover any cost. But as a practice, though, that just doesn't pencil out for us because we are still in many ways under fee-for-service. And so fee-for-service just really does not work in terms of payment, appropriate payment incentives for this population of patients. And so that is a bit disheartening, but I will end with hope. I think the future is bright for palliative care as our system moves more and more toward a total cost of care environment, because it's easy to see how accountable entities can really generate a positive financial return on palliative care and more intensive care of the seriously ill. But it's just going to take some time to get there. So I'll leave it at that.
Excellent, thank you. Jay, any comments?
Well, I think, Walter did such a great job. We'll let, Walter have the last word today for the last 2 days. But just to reinforce what I think we heard from a lot of people, we're getting to the point where, and especially as we move forward on the glide path, these payment models, if we really want to see the change, the total cost of care, they're going to have to be mandated. And, we'll give people long enough runway to phase things in. But if they're going to want to continue to see Medicare patients, they're going to have to participate in programs. And, the incentives in the system are not aligned. That's why hospital CEOs got rid of the geriatric fellowships. They don't get paid for cost savings. They get paid for revenue generation and profit. And they weren't profit centers. And they closed like half the geriatric fellowships in the country. And until we move to a total cost of care, when that's where they truly add their value, as well as taking great care of patients, we're not going to get the change we need. And the other issue, and this gets to Lauran, in terms of equity, there are areas in this country and in the city of Philadelphia where you can't get a home healthcare worker to visit somebody who's homebound because of the neighborhood they live in, and it's not safe. And that gets to a whole other systemic issue in terms of violence in society, but that's a reality. You can't get providers to go places because it's just not safe. So, that just adds to the equity issue and the care issue. So, it's systemic. Like Walter, like you, some days I get more depressed, but, I think, if you don't have hope, why get up in the morning, right? So, thanks everybody for their participation, attention. It was a great couple of days.
Well said. Other committee member comments? Yeah. Well, I'll add my own comments, which this time are brief. You all have done a wonderful job summarizing just a phenomenal day. I agree. Thank you so much to Walter, to you and the PCDD team, our NORC colleagues and staff for putting together a phenomenal 2 days. And you grounded us well in focusing on a specific complicated patient population that is heterogeneous. But I too am going to leave with a couple of comments around optimism. I think we talk often on this committee about identifying the ideal care model and then layering on top a payment model with incentives or disincentives to try to ensure that that ideal care is provided in addition to essential care being provided. And what I learned over these 2 days is this is actually one area where there is a lot of excellent evidence that tells us expertise, longitudinal relationships with trust, for which we can better understand a person's goals, and availability are the secret sauce to immediately decrease cost and improve quality. And there are ways with payment to make that possible that we haven't chosen to prioritize. The other thing I heard is sometimes we talk about what are the potential low-lying fruit. And I'm hearing us have an opportunity because we're tripping over watermelons. And that's around mandating that certain activities occur, including collection of data elements that would have a immediate impact in us being able to identify patients. So be that a mandatory assessment around functional status we kept hearing over and over, and around we heard conversation around being homebound or even living alone. And I love Freakonomics. And I think what I heard today are a couple of real pearls in that space where we could think about how that might be something that's incented or made mandatory. With that, before closing, I'd like to check with our staff team to see if they have any clarifying questions for us. Audrey, no questions. All right. Again, I want to thank everyone for participating today, our expert presenters and panelists, my PTAC colleagues, and those listening in. We explored many different topics regarding addressing the needs of patients with complex chronic conditions or serious illness in population-based total cost of care models. Again, a special thanks to my colleagues on PTAC. There was a lot of information that was packed into these 2 days, and I so appreciate your active participation and thoughtful comments. We will continue to gather information on our theme through a request for input that's based on the topics that we discussed today. These will be posted on the ASPE PTAC website and sent out throughout the PTAC listserv, where input to our questions can be offered by July 8th. The committee will work to issue a report to the Secretary with our recommendations from this public meeting. And with that, I get to do this for Angelo. The meeting is adjourned. Thank you.
Produced by the U.S. Department of Health and Human Services.